Hi guys, so welcome to part 2 of this patient that I saw. So the patient that please watch part 1 before you come and watch this part 2 so that we can be on the same page. So we said this patient was assessed as query oral candidiasis, querying renal impairment. So based on our blood results that we saw earlier, we were able to rule out any form of renal impairment or renal failure because our creatinine for this patient was 39. Our urea was 5.5, sorry. Our GFR, glomerular filtration rate was above 60. So based on this, our patient didn't have any form of renal. So the anasaka or the swelling that she had was not due to any renal problem. So we are done with that one. We are happy. So now the next thing is we also did mention that our patient had a HB of 8.5 and an MCV of 87. So by definition, we said this is normocytic anemia, right? And then we said that our patient had a CRP, and I did explain what a CRP is, of 257, and then a white cell count of 20.41. She also had a total protein of can't remember, but it was low, but the albumin was 10. So like I said, that based on these results, what we know is that we have a normal renal function, we have a severe hypoalbuminemia, we have a leukocytosis, we've got a very high CRP. So this is infection, it's pointing towards infection. Even though at that point we didn't know where the infection was coming from. We did a chest x-ray, we didn't see anything on the x-ray. We did a dipstick. Like I said, we did a urine dipstick. The things that we saw in the dipstick, it was tryptase protein, there was no blood. And also, she had no nitrites or no leukocytes. So, by this, she didn't have a UTI. So, okay. So at this point, this is what we had. And we said that I thought this patient had a nephrotic syndrome. That's why she was so swollen. So guys, when you have a patient that has got anasaka or has got swelling, differentials for a patient who has swelling should be, so when you've got a patient who has got swelling, think about right heart failure, think about congestive heart failure, CCF, think about portal hypertension. I'm talking about now swelling of the legs, like both legs, right? Swelling of the legs. Think about those things. Obviously, you hardly have swelling of the face in other conditions. Most of the time when you've got facial involvement, it's usually a renal cause. Think about renal failure. So for those who are doing, for the students, when you've got a patient, if they give a patient that's got swelling of the legs, These should be differentials. So which means now your history should try and rule this thing out, and also to try and your also examination should also try to rule these things out as well. And don't forget low albumin, hypoalbumin. Don't forget it as well. So for the swelling of this patient, the doctor who saw this patient thought that this patient might be having one of these. But the fact that our UN is, so she was able to rule renal failure or renal impairment out because of those. Now, the another thing that was left was this, but she didn't have portal hypertension features, she didn't have CCF or right heart failure. But our bloods did confirm that she's got a low albumin. So her cause for the anasaka or the swelling of the body was a low albumin. There are other causes of swelling as well, like you can have. There are not a lot though. These are the main ones. Because now I was thinking, if you've got portal hypertension, if you've got liver cirrhosis, what causes you to have swelling is the portal hypertension, because you get an increased pressures in the portal system, because now the blood is not able to pass through the liver that has become cirrhotic and all of that. So I don't want to put renal failure alone here, because it's not not renal failure. I don't want to put liver cirrhosis alone here, because what causes swelling of the legs in liver cirrhosis is the portal hypertension. So now why would a patient with low albumin get anasaka or swelling of the whole body? So I hope you remember the hydrostatic pressure and the oncotic pressure. So basically, we have got we've got arteries. We've got arteries, they become small, and then we've got veins there. So we've got an artery, arterial, capillaries, and then we've got venules, and we've got veins. So basically, when you've got a lot of, on the arterial side, because this side is closer to the heart, there's a lot of pressure at which the blood comes with. So there's a lot of blood and a lot of pressure that is here. So, and it's trying to pump blood against a narrowed capillary or a narrowed arteriole or venule. So what happens is that you tend to get water that gets out because of this hydrostatic pressure that is high here. Then this water seeps out into the interstitium, the cells. So it escapes from the intravascular space and to the outside. It's fine. There's nothing wrong with this. It's okay. But it's okay because at the end, you have another pressure that will take this water back from the outside. And that pressure is the oncotic pressure. But now you develop swelling when this oncotic pressure is not doing its job. You just have the hydrostatic pumping water out, and then at the end you don't get the oncotic taking that water back into the intravascular. So you develop swelling. So these are cells. It's outside now. You get a swollen face, swollen legs, swollen whatever. So, but this oncotic pressure, so we said this is hydrostatic, and this is oncotic pressure. So this oncotic pressure is dependent on the amount of albumin in the intravascular. So the higher the albumin, the easier it is for the pressure gradient to be created, and then you get water going back. But now if you've got a low albumin, this ability of water moving back becomes impaired. So now the water stays outside, then the patient becomes swollen. So in this patient, she had a low albumin. So this is her problem. This is the problem that she had. It wasn't one of these, but this is her main problem. But now, this patient was a very not easy patient to manage, because she had a BP of, what did we say? I think it was 60 some 90 what 3 over 60 something, I think. Yeah, if you can check part 1 of this, you're gonna see the number. I can't remember it now. I remember the pass was 114. I remember the RR, it was 40. I remember the sets were 94 on room A. That's fine. So now the dilemma with this patient is that she's fluid overloaded, and you want to give this patient Lasix to take out the excess water. But now you've got hypotension. The minute you pump a lot of Lasix into this patient, she will become hypotensive. That's the first problem. Another problem is that if you say to yourself, okay, let me give her fluids, when you give her fluids, you're gonna increase the hydrostatic pressure more. You will increase the blood volume, and the water that you will be giving this patient, the fluids, will keep seeping out and worsening the edema. So which means that the rate at which the Lasix is given and the rate at which the fluids are given should really be monitored, because that fluid that is excess in the body will need to move out. It was fortunate that this patient didn't have pulmonary edema, because that is the one that was gonna cause problems for her. Because imagine if you've got water in the lungs, you can gaseous exchange cannot take out all your alveoli are full of fluid. I was so happy that the lungs were clear, and then she had a good entry on both sides. We did an X-ray. She had no effusions. She had no fissures of pulmonary edema. So it's important that she receives a diuretic to take out the excess water, but also you don't want to push her into hypotension. So the problem, that one thing that she needed to correct all of this was for her to receive albumin. And the ideal, I remember the internal medicine doctor that I was discussing this patient with said that giving her Albusol, which is an IV albumin, wouldn't really help, because Albusol only lasts for about 24 hours in the system. It has got a short half-life, so it wouldn't really help. So that's what she said. Okay, but what she needs is a high protein diet, and you don't want to because you want to replenish that albumin. So you want that liver to start making albumin. So you want to give the patient you want to give this patient high protein diet, so that she can start replacing the albumin. And once you start getting a lot of albumin now in the body, then the oncotic pressure will start doing its job. What else am I missing here? So obviously, when someone is like this, remember, when you've got a nephrotic syndrome, you don't only lose in the urine, you don't only lose albumin, but you lose all proteins, like your complement proteins. And we know that complement proteins are very important to fight off bacterial infections. So this patient is prone to infections. At this point, on top of her being HIV positive, which is an immunosuppressing condition, she now has got nephrotic syndrome, which is also an immunocompromising condition, because you lose complements and you also lose other immunoglobulins in the urine. You also lose like your coagulation protein as well. So this patient is prone to bleeding, is prone to infections, so, and already we can see that she's got a white cell count, so she has got an infection going on. So she needed to be given antibiotics, and on top of that, she needed to have her urine taken for MCNS to look for UTI, plus, and also to do a urine creatinine ratio. Remember, by definition, you should lose about 3 grams of protein in 24 hours to say 3 grams or more to say that you've got a nephrotic syndrome. So that needed to be confirmed as well, and also to rule out the cause. We are going to talk about nephrotic, the management, how they present, how they differ, and all of that. And now let's talk about her anemia. Someone who's got anemia by a rule of thumb, you should receive a transfusion if your HP is less than 7. I know there are patients who walk around with a HP of 5 and 6 and all of that, but they're not symptomatic. So especially those people who've got chronic anemia of chronic disease and all of that, they're not always transfused, even if it's less than 7. But other patients, when they've got a HP of less than 7, they are transfused. Now, this patient has got a HP of 8.5 with an RR of 40. You don't know whether this RR is due to that anemia, like she's developing symptomatic anemia. We are going to talk about anemia and its workup, and what do we mean when we say the patient's got symptomatic anemia. So when you've got anemia of more than 7, but you are symptomatic, you should receive transfusion. So she also needed to be worked up for anemia. We are going to do an anemia workup as well. How to do an anemia workup. Yeah, I'm not sure if I'm leaving anything. So I was happy to refer this patient to internal medicine because it's not an easy patient, because there are so many things you need to look at in this patient. So they admitted the patient and then they took over the care. So yeah, guys, that's a patient that I saw on Friday morning. I hope you enjoyed that, and please feel free to comment, like, to share, and all of that. What is very important that, guys, you must remember is the causes of swelling. Remember these causes of swelling. So that not everyone who's got swollen legs has got CCF or right heart failure. Think about low albumin. Think about portal hypertension and its causes. And one other thing that I hope I didn't do it, but I'm just thinking about it now. One other thing, remember, in casualty, it's hard to do everything. When you're in the ward and seeing patients, you can start doing things that were not done. When you've got a patient, as much as my patient didn't have any stigmata for liver disease, with that low albumin, INR should also be done to see if she might be getting in some kind of liver failure as well. You don't want to say that you don't want to be surprised by a liver failure that develops when the patient is in the hospital. Yes, we know that the most likely cause of her low albumin is because she's leaking protein in the urine. That's okay. But another cause that will kill the patient of a low albumin is liver failure. So you want to do an INR on this patient and check that as well. So maybe I will need to go and see this patient and also just maybe talk to the doctor that is in the ward, just to make sure that is also done as well. So guys, thank you so much.